Good morning, everyone. Welcome to the IHPBA meets SSAT Symposium on borderline resectable pancreatic cancer. My name is Mark Callery. I'm from Boston in the United States. I'm representing the SSAT, and on behalf of the executive leadership of the SSAT, the Society for Surgery of the Alimentary Tract in the States. It's the Surgical Society of Digestive Disease Week, as many of you know. The principal executives that send their welcome are Dr. Nathaniel Soper, immediate past chairman of the board, Dr. Stan Ashley from Boston, the immediate past president and current chairman of the board, and Dr. Stephen Stain, the current president, and they deploy me, the president-elect, to come over here and have the session today with you. So we're looking forward to doing this. We have some really superb speakers. We're going to be talking about a disease that's in good faith trying to change paradigms, trying to get more patients to the operating room for a purpose that really will help them. A lot of things have changed, a lot more are going to change, and without taking any of the thunder from the speakers who are going to go through all of this for you today, and we'll welcome at a panel as many questions as you can. When you do come up to the microphone, if you could wave or send up a flare or anything, because I can barely see any of you up here right now with this spotlight, and introduce yourself and where you're from for all of our colleagues. So with that, I'd like to introduce my co-chair, Michelle D'Oliveira from Zurich, Switzerland. Michelle?
Thank you, Mark, for the introduction. Good morning, ladies and gentlemen. So today is this joint session that's very important. We are keeping that for the SSAT and the IHPBA and IHPBA. So we have an expert today that will show us how we will approach those patients with borderline resectable patient. What should we do the workup for the preoperative, how to select those? Is neoadjuvant therapy indicate for all those patients that the criteria we think will fulfill? How should we explore them? Should we go through laparoscopic approach? Should we do explorative laparotomy? And how to access that? Is that really worrisome to go for mesenteric portal resection axis or the arterial resection? Should we go for that or not? So maybe it will be a very exciting discussion in this audience. And how about the future? How can we improve our outcome? How will be the best marker for the prognosis for those patients? So today it will be very exciting, and I would like to introduce the first speaker, Dr. Scott Helton, the head of the HPB surgery at the Virgin Mason Medical Center. Please.
Thank you, Michelle, and good morning, everybody. I want to thank the organizing committee for inviting me and participating in this interesting topic. You can see I was assigned a broad topic to discuss why, what, when, and how we're treating patients with borderline resectable pancreatic cancer. So I'm going to address each of these topics in segments, and I'll start with addressing why are we giving neoadjuvant therapy to patients with this disease. And no pun intending, it's because Mark Callery said we should. 10 years ago, the IHPBA, in collaboration with the Surgical Society of Oncology and ASCO, convened the first consensus conference on managing borderline resectable cancer, and it was published in the Annals of Surgical Oncology. At that time, there were basically case series. There's very little data to generate consensus, but nevertheless, this publication sort of set the baseline or the foundation to address many of the issues. And as I'll address and I'll show you in many studies subsequently carried out, the basic clinical design is followed here, and that is complete staging, followed by chemotherapy first, repeat staging, chemo RT, and then finally operation. That is provided kind of the paradigm. Now, since that original consensus conference, there have been many other consensus statements. Here is the ASCO guidelines, which basically stated that when there is involvement of the visceral vessels, that is a hard indication to consider neoadjuvant therapy. There are other reasons to consider neoadjuvant therapy, but I'm going to stick with the definition of borderline resectable, which essentially means involvement of the vessels. So let's spend more time on the why. First, pancreatic cancer, we all know, is a systemic disease. Everybody pretty much has micrometastases at the time of their presentation. Surgery alone rarely cures this disease. In fact, 60% of patients after successful operation will develop metastases within 6 months. Hence, the guideline to give systemic adjuvant chemotherapy for all patients with all stages of disease. And as we know, through the SPAC trials, that established the standard. But as we learned from the CONCO-1 trial, only about 60% of patients even receive their full adjuvant therapy due to one reason or another. Conversely, when one gives the chemotherapy up front, there's the opportunity to give it to 100% of patients. Now, because borderline resectable involves the vasculature, those patients are more likely to have a positive margin, positive lymph nodes, lymphovascular invasion, perineural invasion, and even peritoneal disease, and earlier systemic recurrence. So it's logical to treat these patients up front to improve the chance of attaining a R0 as well as downstaging the disease. 20 to 30% of patients have unfavorable tumor biology, and we know that they will develop early metastases while even on chemotherapy, identified prior to operation. So for these patients, if they can be identified before operation, they're actually spared the morbidity and the potential mortality of what would otherwise be a non-therapeutic operation. Furthermore, patients found to progress on neoadjuvant therapy can immediately be switched to second-line therapy, as opposed to waiting 4 to 6 weeks after a non-therapeutic laparotomy. That delay in surgery creates, therefore, a biologic window which can be used to better select patients most likely to benefit from an oncologic operation. We also know that it provides an opportunity to assess the patient's tumor's response to therapy by conventional RECIST criteria, but more importantly, by looking at the biologic markers, the change in CA19-9. Some places are using change in PET scan or a combination of those two things, and the absence of progression. And a study by the MD Anderson group showed both for resectable and borderline resectable that giving neoadjuvant therapy up front is more cost-effective than surgery-first approach. We also know that the surgeon can more accurately assess a patient's physiologic reserve and their ability to tolerate a major operation if they receive their neoadjuvant therapy. And those who do not tolerate neoadjuvant therapy, it's a powerful predictor for them also not to be able to tolerate operation. Interestingly, just about every major series that's reported on their experience with neoadjuvant therapy has reported a reduced pancreatic fistula rate. Christine Ferrone is here and she may discuss this, but in their paper with 40 patients following FOLFIRINOX, they had 0 pancreatic fistulas, but it's been a consistent finding. Large clinical series show that patients who receive neoadjuvant therapy compared to an upfront surgical group have better survival, increased time to recurrence, a downgrading of their liver node metastases, downgrading of lymphovascular invasion, smaller tumors, up to 10%, a complete response, reduction in lymph node numbers, and improved R0 rate. In those theories that use combination chemotherapy followed by chemoradiotherapy, the R0 rate is in excess of 90%. Now, coincidentally, when Mark asked me to give this talk there a couple years ago, there was no prospective randomized trial. Here's the first one that was published just this summer. Now, this is a very small study, but nevertheless, and it uses sort of an outdated chemotherapy regimen of GEM plus XRT, but notice only 27 and 23 patients in the groups. But when analyzed from an intention to treat perspective, on the interim analysis of this trial, there was a substantial reduction in or an improvement in survival in those patients given the chemo-RT. And the Patient Safety Monitoring Committee made them terminate the trial early because of that. And then there was the PREOPANC study by the Dutch Pancreas Cancer Group that was presented just this spring at ASCO. And in this prospective randomized trial, it includes both upfront resectable as well as borderline resectable. About 50% of the patients were borderline resectable. And you can see that the R0 resection rate was substantially higher in those that got the chemotherapy first, that the distant metastases-free interval, the local regional recurrence were all improved, and that for those patients that were able to tolerate the whole regimen and undergo operation, you can see that the median overall survival was substantially greater compared to those with a surgery front. These results are as good as any clinical series in the world. They also did a meta-analysis, and I don't know if this, there we go. You can see that in all these neoadjuvant groups that the overall survival was better compared to upfront resection. So the bottom line is, to answer this question, why, patients who complete all intended neoadjuvant therapy, including an operation, have overall survival that is unmatched by a surgery-first approach. And we are now starting to see the emergence of at least 2 prospective randomized trials that are confirming this observation. So what? All sorts of different neoadjuvant therapies are being explored. There's chemotherapy alone in the form of single agent, doublets and triplet medications and combinations, chemotherapy plus biologic response modifiers, induction chemotherapy followed by chemo-RT, and then there's different types of chemo-RT and dose intensification, including intraoperative radiotherapy, and then finally, chemotherapy plus immune modulation. The NCCN guidelines, updated versions just last year, have shown that combination therapy is now the gold standard. One of 2 regimens, either the FOLFIRINOX regimen or the GEM albumin-bound paclitaxel. No head-to-head trial has compared these 2, and they're both felt to be similar, though kind of most of the larger series in the world have endorsed the FOLFIRINOX, though it's a bit more harsher. And then for those who have a BRCA mutation, GEM plus CIS. So those are guidelines from the NCCN. This recent publication from the Wisconsin group looked at a novel way of taking the FNA specimen, doing molecular phenotyping, and defining 1 of 5 chemotherapy drugs based on the molecular findings, with a substantial improvement in median survival, as you can see here, with patient-specific information. And this is a study also just published by Christine Ferrone's group from Mass General, using either gem-Abraxane combination or FOLFIRINOX for 8 cycles preoperatively, followed by chemo-RT, going to the operating room, and then offering intraoperative radiotherapy as well. And again, you can see a median survival in excess of 40% for those patients that complete the regimen. This is a fantastic study I encourage everybody to look at by Dave Linehan's group when he was at Washington University, and that's combining FOLFIRINOX therapy along with an immune modulator, an oral pill that one takes that interferes with the chemokine axis that recruits tumor suppressive macrophages into the tumors. And what they showed in combination was, and this was predominantly patients with unresectable disease, but they had a subset of borderline resectable patients in there. They saw almost a 50% objective tumor response, 97% local tumor control, 71% of the patients that had borderline resectable disease were able to be resected. And the interesting thing about this study, they hypothesized that they could change the immune environment within the tumor, and they basically flipped it from a suppressive immune environment to one where the T cells were upregulated within the tumor. So this is a unique approach, and we'll be seeing future prospective randomized trial looking at this combination. This was the first study by the Alliance Group to establish the feasibility and the tolerance of these patients, borderline resectable patients, to undergo FOLFIRINOX followed by standard of care chemo-RT surgery and then additional chemotherapy afterwards. It was just a feasibility study to look at recruitment. And if you look at the R0 resection rate, 93% of patients achieved an R0 resection. The therapy was well tolerated. You can see that 22 out of 21 completed the therapy. And this led the basis for the next trial, which is shown here. In this study, where patients were randomized to FOLFIRINOX plus minus XRT prior to surgery, this study was designed to have an interim analysis after 30 patients were randomized to both groups, and was just halted a couple weeks ago for the interim analysis to judge whether or not we should continue. And so this particular trial is going to generate some very interesting information. Then we have the SPAC-5 trial, which randomized patients to 4 groups: immediate operation versus GEM-CAP, FOLFIRINOX, or just upfront radio chemotherapy. This is a trial just to show what we're doing at Virginia Mason. In order to overcome the resistance, this is a combination therapy that switches between 2 different regimens, gem-Abraxane, and also a liposomal irinotecan, and you can see that they switch back and forth, and then they undergo operation. We just started this phase 1B study. Now let's address how. How should we be giving neoadjuvant therapy? First, and these are consensus statements out of the NCCN guidelines, consultation at a high volume center is preferred, and treatment at a high volume center is preferred. And finally, participation in a clinical trial, so we can really try to figure out what is the proper sequencing and combinations. The clinical trial design should have well-defined selection and exclusion criteria. They should have consistent and universally applied definitions, central radiology and path review, and again, a high volume center. In taking care of a lot of these patients, in order to get them through the therapy, it's really important to have fastidious follow-up of them to address toxicity and appropriate dose reductions in order to get them through. It's well known that if patients are jaundiced, that their bilirubin should come back down to normal prior to starting therapy, and the use of a self-expanding metallic stent over plastic stents is really important so that therapy doesn't get interrupted when the stent becomes plugged. And then patients should be restaged regularly during the neoadjuvant period and prior to operation in order to exclude progression and to measure the response. How about when? There's no consensus yet reached regarding the ideal timing for exploration following neoadjuvant therapy. You can see intervals as low as 3 to 4 weeks, but the majority of the studies that are ongoing right now pick a period of time between 4 and 6 weeks after completion of neoadjuvant therapy. In the PREOPANC study, it was greater than 4 weeks after chemo-RT. So what do we know now? We know that neoadjuvant therapy in this patient population is safe and feasible. Local disease progression is very unlikely. Systemic disease progression, however, occurs 25% of the time, so those patients are spared the morbidity of a non-therapeutic laparotomy. The majority of patients are able to get through the regimens, and we know from almost all the large series that the regimens do not adversely impact postoperative outcomes, and in fact, there's a reduction in major complications. We know that there's improvement in the R0 rates and survival, and to be cost effective. The unresolved issues, which I think the other speakers will address in part, is treatment sequencing. We don't know what the right sequencing is yet. The specific elements and the combinations, that's the Alliance trials have formed a baseline upon which to build to look at these things. The duration of therapy, this is very controversial, but there is no head-to-head study yet that has shown is 2 months, 4 months, 6 months, which of those is better? We just don't know. And then finally, the value of radiation needs to be tested in clinical trials, and that Alliance study I quoted is going to do just that. But there's the type of radiation, the timing of the radiation, and the dose intensification, all of which are important. And then finally, this is an outstanding review of just about everything I've talked about and other studies as well that I refer the audience to if you're interested. Thank you very much for your attention.
Thank you very much, Dr. Helton. That was outstanding. It's a particular pleasure for me to welcome our next speaker, good friend, colleague, Dr. Christina Ferroni. She's from Harvard Medical School in the famous pancreatic surgery unit at the Mass General Hospital. And she's going to be talking about surgical strategies that are unique and specific to borderline. Dr. Ferroni.